Thanks, Ajit. Okay, so we're kind of changing our algorithm here. So what we're going to do, the idea here is really not to trick people or come up with crazy answers, but really to see kind of what everybody's thought processes are in terms of how you would really manage this in the real world, in the sense of, does it have to be, we have different options now for, patients that have, close to a desert foot, right? We've got, pedal loop interventions, we've got DVA, we've got other things we can talk about. And so here's a patient, classic CLTI patient, came to the office, and you can see the toe PPGs, there's really no waveforms to the toes. I mean, they're basically flat lines. So the question becomes, when you look at this angiogram, and there's no inflow disease, the FemPop segment is normal, relatively speaking, but really you're dealing with this type of patient. And so what we want to get to is, what do we do here? I think we've had a lot of talks today about, what our options are. We have a lot of tools, a lot of devices, but maybe we can go down the panel. We can start maybe with Dr. Wiley and see what your thoughts are looking at this in terms of, should we just, what should we do here?
Yeah, this is a difficult case. In my experience, pedal reconstruction has not been very successful. It lasts for about a month and then it closes down on me. I don't know if it's the technique I use. Some others seem to do better. But in this case, probably doing a prolonged balloon angioplasty, if you're able to cross and get into a distal luminal area, may be okay.
Yeah, I think the first issue here is, can you identify a target in the foot, either by advancing a wire down there and getting a microcatheter down there and shooting to see if there's a hypernating vessel, or just extremely delayed views. Even if you don't see something, you can use duplex to do retrograde access to see if you can get into something. But this is a challenging looking angiogram, especially considering the appearance of the foot. So it's one where I would think about some sort of deep venous arterialization strategy, although I think the jury is certainly still out on that as a technique. But that may be the only option for a patient like this.
The key point in that case, that seems to have no connection and maybe no remaining dorsal nor pedal arch. That could be the very bad point in that case. But we could be surprised. I think we have to reach the anterior artery to try. There are some remaining parts. I think it's not fully occluded, and in such a case, dealing with a support catheter plus a dedicated guide wire, we may reach the dorsal arch and we may reopen the wall access down to the foot, because the clinics doesn't seems to be so bad versus the angiogram.
Dr. Brodman?
I would also try to reopen and go as far down as possible, and DVA will not be my first choice. This will be only if we are not succeeding and the patient is getting worse, then I would switch to DVA. This would be not my choice, because as Eric has said, sometimes we really see down to the foot, if you try to reopen it and do the angiogram, that there's flow coming and you see some kind of vessels, and I think you should try everything to do this in the regular way with just endo first.
Maybe we can go quick with George, Al, and Ajit.
Yeah, I mean, there's a huge disconnect between the clinical situation and this angiogram, which makes me think that you're going to be successful probing this. I mean, somehow, some way, there's some sort of oxygen getting down there, because you don't have just an entire mess of a foot up to the ankle. Yeah. So I think you do whatever you've got to do in the traditional manner, and I think you'll have some luck.
You've demonstrated some nice reveal of hibernating vessels. There's a little squiggle of an AT there, even a tarsal branch. I think you'd be surprised, but if the success in terms of getting that open is work, the DVA and the backup.
Yeah. Anything to add, Ajit?
No, I agree. I mean, try probing for a hibernating vessel, but I would, go to DVA as the next step.
Yeah, I think the main thing is just having an algorithm approach. I mean, Brian said something that I believe in too, is I think there may be a lot more hibernation going on here than we realize. I think also I have antegrade access. I have a catheter in the P3 segment of the popliteal artery to get really good imaging. Delayed imaging helps. Putting an ultrasound on the dorsalis pedis and seeing is there a lumen or an artery that is that is open, I think would help tremendously. But I think the main thing is you have to cross. And so, not to belabor the point, we did cross. There is a lot of hibernation. If you look now angiographically, I mean, there's a lot of flow below the ankle. And I think that's the key takeaway for a lot of the early career and kind of the fellows and trainees, is that until you cross, until you look, you don't really know what's going on distally when you have multi-segment occlusions. And then you can see, go ahead, yes.
Please, also in that case, if the anterior artery was very easy to reopen, what we may do also is to treat also the peroneal artery, because there is a distal distribution here.
Yep, agreed.
Question of time.
Agreed. So then, obviously, physiologically, we have we have improvement, which again, that's a big thing. Non-invasive testing makes a difference. It really helps you follow these patients, as we all know, and then on exam, the patient clearly is going to do better. So next case, a little bit different story. This is a patient who has non-healing ulceration. And has the classic, Pseudomonas infection that you can see here, which obviously has to be treated in addition to the arteries. You can see heavily calcified fem-pop segment and tibials. And now we've got an occlusion really above the knee joint in the popliteal artery. There is, reconstitution of pretty robust, TP trunk, perineal, and posterior tibial artery. So now the question becomes, do you tackle this endovascularly in your practice, or should we go straight to bypass if they have a good vein? I mean, Dr. Ducassi talked about this. Sometimes operative management first and early makes a difference. So what would most of you do here in this setting? Clearly we're dealing with infection, superimposed infection as well.
Well, not just because there's multiple specialties represented here, but I think this is, if you've got a vascular program, this is a situation where you need to have some collaboration. Get the opinion of the surgeon if you're not the surgeon. If you're the surgeon, get the opinion of cardiologist or radiologist.
And this is pre-IVL, so we don't have IVL here. So it's not to trick you. I'm just saying this case was pre-IVL, so it's a tough case.
I think the other thing that's important to recognize immediately is this is not arterial disease. This is a combined arterial venous insufficiency, and to not address the venous component is a problem. Conversely, if you think this is just venous disease and you compress this patient, they'll get worse because of the ischemia. So you really got to tackle both of them. And these patients with extensive necrotic wounds and combined arterial venous disease are the hardest ones to treat.
So the patient did have GSV reflux, Brian. You're exactly correct, and that was treated at an outside hospital with above knee RFA and below knee Varithena, foam polydocanol at that time, with no real change. Improved the edema a little bit, but didn't get significantly better.
You means that we may use the GVS for bypass?
Anybody else? Ajit, would you
Think holistically.
would you try endo here as well? I mean,
Well,
given
yeah.
the circumstances.
I mean, I'd worry about, the other kind of point is I'd worry about wound healing in this case, right? You have a pretty significant wound. I can't tell if it's going to come close to the surgical site, and then especially if there's no vein and you're using graft, the leg's going to swell a ton. So I think, especially if you're telling me there's no vein, I'd probably try endo first.
Yeah, and that was really the assessment of our vascular team as well. The surgeons looked at this and said, look, with that infection, we do not want to operate on this patient, even if we have a good vein. We would love to, at least try to get some interval clearing, interval healing if possible. And even though we didn't think we'd get a great result from an endovascular standpoint, they said, go for it. Let's see what we can get, and we can always have the option later for surgery. And so, looking at this case, I knew right away we need, access from above. I know we need access from below. I didn't think, I could cross this primarily. You can see it's clearly subintimal from the beginning because you're dealing with really dense coral reef type calcification in these arteries. And then, using all the traditional techniques that we're used to, basically, you have a lot of different options, right? Cart, reverse cart, safari, etc. all the things we knew. We crossed. We could not get good balloon expansion or luminal gain with angioplasty for obvious reasons. I think in today's world, IVL here would be very good and would get a good result, robust result. But what I opted to do is rather than putting in stents and scaffolding this, I decided to do POBA followed by DCB. And I said, let's see what happens. We have some other options surgically and so forth. And you can see we did get physiologic improvement with an ABI from 0.45 to 0.92. You can see we have somewhat of an angiographic wound blush, which is a good CLTI endpoint, as we know. Eventually, the patient cleared the infection and got significant healing, and then, went on to do well in this case. So another patient, again, patient was seen by 2 physicians outside and was told, you're an amputation, there's nothing else to do. You can see there's a deep ulceration in the lateral part of the foot. Clearly has all the hallmarks of chronic ischemia that we're dealing with. And then angiographically, this is what we're dealing with as well. You can see, again, we've got, basically below knee disease of significance. And you do have a little bit of a distal posterior tibial artery. So, given where this wound is located and given what you see here, do you think there's a surgical option here to start with right away? Or do we, again, need to probe and try something, from an endovascular standpoint? I know most of us would say, yeah, we'd like to lean towards endo and give it a try. You're already there. But realistically, if you saw this patient in the office, what would many of you think here? Brian, anybody?
One of the things I just want to point out, this is why to I think George's comment about using a multidisciplinary approach, these both are the same type of patient, meaning POP to distal bypass, which is not a very extensive operation depending on a number of factors. But here, the distal target is all the way at the ankle. It is very small. And so there's a little longer distance you're traveling, but really you're going to put your wound further down the leg, and you're going to sew to a very small artery. The last case was a distal SFA or above knee POP to a proximal PT bypass or TPT, which was a really robust vessel, very different operation. So these 2 patients are essentially the same thing, a POP distal bypass, but they're actually very different in terms of how I would look at them. So that's why having a surgical input is worth having for these type of cases. I would approach both of these endo like you're doing here, but I think that discussion's an important one.
Yeah.
Dr. Broadman, Ajit, anybody else? Yeah.
I would also do endo first and try to restore the blood flow and see what happens. And but endo first would be my first option, to be honest.
Ajit?
Yeah, I don't think that's a great bypass target. So definitely, if there's no vein, I don't think PTFE is really going to hold up in that.
Yeah.
So I think endo first might be a good option in this case.
Yeah, and that's what we thought too. And again, going back, again, the duplex ultrasound really helped us here. We saw that there was a hibernating dorsalis pedis artery, and we thought, this, and you can see we have a little bit of a nub of that AT and that TP trunk, so we have some options to at least try. And remember, angiographically, just because you don't see things for the fellows in early career, is realize that there may be more there than meets the eye. And so you can see we did the kind of the classic thing. We got retrograde approach. I had antegrade access in this case. Placed a sheath in this case because the artery was occluded in that distal AT anyway. And then basically crossed very easily from below and thought, we're done, already got there, and then realized that we were in 2 different subintimal planes. And then for the fellows, obviously, you can see that we have a couple of different options here. One option is cart, reverse cart, all the things that we're very familiar with. And then you can basically, create your channel, get through and through access, and then, externalize your wire, reverse your access, etc. The other option also is something that, Fadi Saab has really coined over the years, along with Jihad, is Navi bossing, where you're using an 035 catheter and basically trying to disrupt the tissues on both sides of this this subintimal plane to really get through and through access. And this is another technique that works quite well to get you your access. In this case, reversed the access, did orbital atherectomy because it was a heavily calcified vessel on IVUS. Good balloon angioplasty. Had some dissection that we had to deal with, placed some proximal scaffolds in this case because it is a limb salvage case. And you can see really you have a nice, again, good flow, a nice angiographic wound blush, good CLTI endpoint on the table as we discussed. We obviously need better endpoints. You can see the difference pre and post. A lot of hibernating vessels. And so the reason I wanted to show these cases when I spoke to PK is that we decided we wanted to show cases where there's a lot more there than meets the eye when you first do your angiography. So you have to be very careful of saying this is a no-option patient. I think we have to realize that the no-option patient really is a subjective thing sometimes in certain patients. And you can see you got interval clearing, skin grafts. There was a lot of work done as the course of about 12 months and got significant healing in this patient. So, but yeah.
Sure, one comment about that, which is interesting.
Yeah.
Based on that picture, people may have a tendency of going for that PT, but you gave a really good blush as a final result on this with the AT. Often you don't know that, right? So
Yeah.
two things in terms of algorithms.
Yeah.
Do you take the AT for two reasons? One, because it's not going to potentially burn a bridge if you did want to do a bypass, and I gave you a G, doesn't look like a great bypass option, but number
Okay.
two, not knowing what's going to give the blush to the wound.
Yeah, I think if I hadn't seen the patent dorsalis pedis artery, I would not have gone after that AT first in that case. I think the PT would. Yeah, it worked out in this case. Yeah, but it looks like we're going back live. So Jit, I'll let you take over. Thank you.